Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com.
You want to tell us a little bit about your platform so that they kind of get an idea of what they can get into. Tell everybody about RadPod Squad.
Sure. So in my career, I'm an experienced academic radiologist. I spent a number of years in New York under Northwell. And I began to see as a radiologist early in the training years of like 2000 to 2010 that the amputation rate was through the roof. And I was sitting in a room reading MRI after MRI, wondering, are we making any difference? Because it seemed that the amputations would just continue. I looked at the guidelines from the American College of Radiology, and they suggested you get an early MRI when you see a patient who potentially has osteomyelitis. And I began, honestly, with a bit of a bias. I said, why are we not doing better here? And I decided to start with a research project that had me studying about 500 patients who had diabetes, who already had an amputation, and whether or not they got an early MRI. Did it make a difference? And I didn't find at the end of my research that it changed the amputation rate, but it decreased the death rate. And that's in diabetic foot and ankle. You can take a look at that. I surmised that the reason why we were decreasing the death rate was because now we were talking to one another. The surgeon was talking to the radiologist, and we were all collaborating together. And I always had this idea that one of the things that was occurring in medicine was I wasn't seeing the podiatrist enough. I went to grand rounds and I gave grand rounds, but I didn't always see the podiatrist in the loop. And it dawned on me, I need to know who they are, because how will I ever know the clinical really well, or how do I even know where an ulcer is? So It's a very important strategy. And I began to wonder and want to make a collaboration directly from radiology to podiatry. And I created a 24 lecture series that was commended by the American Academy of Podiatric Graduate Medical Education. And all the residents in Northwell had the ability to come to my course, check out my lectures, interact with me. And we saw through polling that they did much better. And we brought in new systems. We even were able to create a system where we had official photo language where the radiologist could see the ulcer when they're reading the case. So we developed all that with wonderful results. But to take it up a notch, what I wanted to do was to really talk globally to the problem that we have in diabetic foot, but just in foot and ankle imaging in general. We do a lot of imaging. Imaging is one of the most important reasons for patients to come into the system for foot and ankle issues. And we want to do our best so that we really can understand how we're going to treat the patient. But if we only have one side of it as a radiologist, just having the pictures, we don't always appreciate the tremendous clinical features. Like in forefoot, you mentioned, a podiatrist can see very quickly that, say, that the second toe is starting to cross towards the first toe, as in a case of a classic plantar plate tear.
Right.
But a radiologist was never trained up through that area. So it may not be obvious that we should be looking for that very quickly if we want to make that diagnosis, right?
Right. Because of our specialty and in peripheral nerve, and we end up seeing a lot of folks that have had failed Morton's neurectomies and different types of devastation surgically induced from the standpoint of attacking the forefoot with all of these different things, where I think if they were able to have a little bit more appreciation of what you're pointing out, like say they have a long second, third, and fourth metatarsal and they have an equinus component, they're pretty much doomed to a high pressure event in that forefoot. And there's not many radiologists that I know of that will say, like you, well, look at the cortical sclerosis in the second metatarsal. That's a very objective finding because of a biomechanical event that's going on in this particular patient. So it gives you a little bit more understanding of everything that's going on. And that type of, just that verbiage in one of your reports is going to change maybe the way that podiatrist or foot and ankle orthopedic surgeon is going to maybe look at that, and could totally change the care that's rendered and the treatment path that they go down. So I think that's an important thing.
Are you ready to take your podiatric imaging skills to new heights? Check us out at radpodsquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.